Hello, everyone, and welcome today to our webinar that we're hosting. My name is Andrew Pinto. I'm a family physician, a public health specialist, and I'm also the director of a group called the Upstream Lab, which is pleased to co-host these events. I also serve as the lead for AI for Excite, a new initiative from the Department of Family and Community Medicine at the University of Toronto. Excite stands for Exploring Innovative Technologies in Family Medicine. And this is the fourth and final webinar in our series this summer, which is looking at how technology is shaping family medicine and other parts of the healthcare system. So today we're going to be talking a bit about the potential benefits and risks of AI applications in healthcare settings. And we have some really fantastic speakers today. Just go to the next slide. So I want to begin our discussion today just by acknowledging the land on which I'm located, which is in Toronto, and which is, I think, where actually all of our speakers are located today. So this is an important part in Canada of acknowledging the history of colonization, but also committing ourselves to a process of decolonization as well. And as you'll hear, this is something particularly important when it comes to artificial intelligence and uses of data. So the land on which I am located now and on which the speakers are located has been the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit River. And of course, today, this is still home to many Indigenous people from across Turtle Island. And we are all very grateful for the opportunity to live and work on this land. Next slide. So we have three fantastic speakers today. We all are from the University of Toronto. And I just want to draw attention for all those attending that it was purposeful to engage speakers from the University of Toronto. We recognize there's many fantastic voices who could speak to these issues from many different institutions, but as some of you may know, the University of Toronto is actually under a censure right now by the Canadian Association of University Teachers, or CAUT. And this is related to the University of Toronto's failure to resolve an issue related to academic freedom at the Faculty of Law. And so we've been encouraged to engage speakers only internally rather than inviting external speakers to University of Toronto events. You can find out more about the censor at censoruoft.ca. So today our speakers include Ms. Samira Addis, who is going to go first, and she is a medical student at the University of Toronto entering her second year. We've been really delighted to have her as a summer student at the Upstream Lab this past summer, where she's been working on a variety of projects. She is also a student this summer with the Temerty Center for AI Research and Education in Medicine. And I should say recently won an award for her work there. Our next speaker will be Dr. Quynh Pham, who is an amazing colleague. She is an assistant professor at the Institute for Health Policy Management and Evaluation at the University of Toronto, and she serves as the associate director for research at eHealth Innovation at the University Health Network. And then third, we have Dr. Amol Verma, who is also a wonderful colleague. He's a clinician scientist and staff physician in general internal medicine at St. Michael's Hospital and affiliated with the Li Ka-shing Knowledge Institute. And he's also co-lead of Gemini, which is a really wonderful initiative to bring together data from general internal medicine wards in many hospitals in Ontario. And he's using this information to improve the quality of care. So thank you in advance to all of our speakers today. So next slide. So I'll just go through our disclosures. These are the folks who are involved with helping plan this four-part series. And we'll mention this at the end as well, but all of these sessions are recorded and posted online for folks to share and to view afterwards. Next. These are disclosures for myself and for Samira. And next. And for Dr. Pham and Dr. Verma as well. Next. So an important reminder for everyone who's attending, please do use the Q&A box to propose questions. We will be collecting these as we go through. And what we're going to try today is have each presenter present. We'll take a few questions and I'll engage with them a little bit, and then we have time at the end to ask broader questions as well. That's great. So next slide. So I wanted to just present for a few minutes, just talking to kind of set the stage for our presentations today. As many will know, artificial intelligence, or AI, is actually a really old concept, and it's a term that was first introduced in the 1950s at a conference of computer scientists. And so for a long time, almost since the dawn of computers, people have been wondering, can we program a computer to behave in a way that it would appear intelligent if seen by a human? And AI is really a broad field of study, and it has grown tremendously over the past decade. It includes not only computer scientists, but psychologists, philosophers, linguists, and many others. And as you'll hear today, people in health as well, including practicing clinicians and people thinking about how to transform the healthcare system. Next. AI itself is composed of many different methods. So the ones that are identified here are some of the more common ones. You will hear a bit about machine learning, which is a process whereby computers are programmed to actually learn from data and from experience and help make better and better decisions over time based on the data that they are using. And there's many different types within machine learning. Natural language processing, which means taking textual data or audio that's been converted into text and making sense of it and finding meaning in that. And then there are others, including computer vision, which uses images and logic programming, many pieces. But the main point is that AI is a broad field with many methods within it. Next slide. So one important kind of spectrum, and I like this figure, is that we're moving really with AI into increasing areas of creating value using this technology. So where we're moving from merely being able to use information to describe something, what happened, to starting to move to understanding why did it happen, what could have been done to help us understand why this event occurred, to predicting the future, to will this happen. And you'll hear, for example, at Dr. Verma's presentation about using this type of technology to predict things. And then to prescriptive, how can we make it happen? How can we, for example, improve health for our individual patients? What would be actually a prescription or idea that's generated that would be optimal for the person in front of us? Next slide. In health and in Canada, this area has gotten a lot of attention. I've just put the covers here of some reports from the Canadian Medical Association, from the College of Family Physicians of Canada, and from the Royal College of Physicians and Surgeons of Canada, all who have in the last few years had task force and major reports that have come out to talk about how this new area is going to influence our care. And so that's partly why we're having this series. You'll hear that something, you may wonder if this was a concept that was created in the 50s, why now? Well, two major things have really driven this. One is the enormous growth in data that is available as electronic medical records, but also things that record our movements, record our inputs from us from our smartphones, from social media. Many different parts of our lives now create and generate data that can be used and then be integrated with our health records. The other thing that has driven this is new technologies and new abilities to process all this data and make sense of it very, very quickly. So these things have really opened up opportunities. And some examples of use in medicine include helping analyze images within radiology, helping to determine treatments for people living with cancer, and helping predict which patients are going to be more at risk. And these are all applications that are happening right now in our health system in Toronto and in other parts of the world. So I think with that, we'll move to starting with Samira to start us off to talk a bit about her perspective and some of the work she's been involved with. Next slide.
Great, thank you, Andrew, for the introduction. Hi, everyone. My name is Samira, and my topic of discussion for today's session is patient engagement in AI settings. So I want to start first with the definition of patient engagement. There are many different definitions that float around, but I like to use the reference, the SPORES definition, which states that patient engagement occurs when patients are meaningfully and actively collaborating in the governance, priority setting, and conduct of research, as well as summarizing, distributing, sharing, and applying the resulting knowledge. An emphasis can be placed on words like meaningfully and actively as dynamic and subjective terms, with the need to be explored by the patient and in their perspective define those terms. So SPORE has highlighted some specific terms as guiding principles to patient engagement, with co-build or co-design, inclusiveness, support, and mutual respect, all of which I'll be elaborating on at a later point in today's discussion. Next slide, please. So what are the benefits to patient engagement, and why do we spend so much time doing this work? Well, there's a wealth of knowledge surrounding this topic. And when patients are setting their priorities and their goals of care, benefits can be seen through the reduction of healthcare costs, fewer hospital admissions, increased patient outcomes, increased quality of life, and improvement to overall patient safety, among others. Next slide, please. So a scoping review is conducted on patient engagement in Canada in 2018, looking to understand the methods and outcomes of patient engagement research. So they succinctly summarize some successful engagement approaches as follows. Some to keep in mind are early patient engagement, defining roles within engagement settings and relationships, providing orientation and education about research and patient engagement, ongoing support and encouragement of patient contributions, and creating a culture of respect when engaging in patient engagement relationships. Next slide, please. So now that we're familiar with patient engagement more generally, how does it apply to artificial intelligence? Well, there are some success stories of active patient engagement within the fields of AI development and healthcare interventions, one of which I'd like to draw your attention to. In a paper recently published titled Co-Developing a Mental Health and Wellbeing Chat Box with and for Young People, the researchers were tackling the use of access to safe, trusted mental health support for youth by creating a chatbot. And through iterative cycles of engagement with youth, who are the targeted end users, they created expert reference groups with psychologists and youth to provide feedback on improvements to the chatbot and to ensure that it was adequate and appropriate to engage the selected population. The paper emphasizes that with collaborations with youth and the importance of creating what they termed as authentic collaborative partnerships. They used terms like co-design, co-development, and these terms emphasize the equal contributions of patients and researchers. Next slide. Now that was a really great example of how patient engagement is used in the development of AI interventions, but how often is this done? Well, to answer that question and understand the ways in which patients are engaged, we conducted a systematic review. So between the years 2000 and 2021, of the 1,400 included papers, which involved the development of an AI intervention affecting primary care, only 70 or 5% included some level of patient engagement or involvement. We found that 46% of the included studies incorporated surveys on usability, satisfaction, or acceptability, making it the most common form of patient engagement across the included studies. And additionally found that of the included studies, only 74% of them engaged students at the earlier stages of development in conception, piloting, and feasibility. Next slide, please. So this leads to our recommendations from our systematic review findings. These recommendations can be distilled into 4 key areas. The first, increasing patient engagement and research rigor so that subsequent research on patient engagement can build on well-established knowledge. The second, to continue patient engagement beyond the piloting stages into the knowledge dissemination and knowledge translation stages. Thirdly, comparing clinician and patient engagement findings to better understand how the incorporation of AI into medical practice can change therapeutic relationships. And lastly, ensuring equal opportunity in patient engagement in a non-tokenistic way. Next slide, please. So evidently, with only 5% of research papers on AI interventions in healthcare with patient engagement, there's a gap in communication between AI researchers and the patient voice. Patients and their caregivers, of course, know their needs best, but also AI developers have a wealth of knowledge on how AI works and are really pushing the barriers of what we once thought was even possible. So we need some sort of alignment between patients' needs and the ability to highlight the issues they face with the knowledge of developers in creating key effective health solutions. And physicians serving as advocates for their patients now have this unique responsibility of bridging this gap in communication and voicing patients' needs and concerns along with their own, and taking a more active role in the integration of AI into healthcare by embodying words like user-centered design, partnership, co-design, and empowerment. But certainly there are more voices at the table like policymakers, data managers, and researchers who are also important to consider. Next slide, please. So in order to understand why only 5% of included studies engaged patients, it's important to understand the barriers to patient engagement. And with respect to AI in the patient engagement field, education is an important point of note. Since AI is new and constantly changing and evolving, it's important that patients and providers both understand the fundamentals of AI in order to serve as active stewards in its usage and advocate for proper usage of the technology. Last Excite session on the usage of data information and privacy and how AI can be used and commercialized against us highlighted the importance of having a good general understanding of what AI is, what it can look like, and the more practical ways it's been incorporated into healthcare, all of which requires education. And it's for that reason that I've created an educational AI module with the hopes of educating patients and providers alike on AI usage. And currently the tool is under development and will be launched through DFCM sometime this fall. So stay tuned on that. Next slide, please. Another important component to be mindful of when working within patient engagement is equity in engagement and recruitment practices. From our systematic review, we learned that of the studies with patient engagement, there were first inconsistencies in the reporting of patient demographics. And of those that reported patient demographics, most of which were comprised of individuals who had high enough education to understand AI, had mild or were medically stable in terms of disease, and had access to support groups in their life. And we want to ensure that a wide variety of voices, patient voices, are heard to make sure that marginalized groups are proactively working and engaging in our research. So with that said, a recent paper in 2020 published in Manitoba created a trauma-informed, intersectional, and critically reflective framework for patient engagement. And in the creation of this framework, they sought out feedback from traditionally underrepresented groups in patient engagement research. So those include First Nations, Inuit and Métis, newcomers, refugees, and immigrants, and those who live with mental illness. They highlighted the importance of trust, honest, safe space to engage, relationship building and reciprocity, self-awareness and empathy, education and communication with patients, in addition to understanding each other's perspectives and building relationships. Next slide, please. So I'd like to end my discussion today with talking about the future of collaborations and patient engagement within artificial intelligence. As I've previously discussed and alluded to, prioritizing patient engagement in artificial intelligence is a collaborative effort across different stakeholders, be it patients, physicians, developers, and policymakers. Establishing these collaborations among stakeholders can serve as a pipeline for adequate quality patient engagement in AI development. And often, and indeed during this talk, I've used words like co-design in reference to collaborations among patients and developers and providers and other key stakeholder groups. I'd like to highlight a paper recently published on co-design in AI, which reviews some key ethical concepts of AI and common myths and misconceptions of co-design. And I'm certainly not an ethicist, but this paper greatly summarizes the assumptions that we should not make when thinking about co-design and how we can measure its strength. Next slide, please. So in order to answer the important questions of how we can collaboratively work together towards quality patient engagement, I'm conducting a qualitative study where we are asking patients and their caregivers, providers, AI policymakers, developers, and data managers on their thoughts and perceptions of patient engagement within the AI field. And we're working towards the creation of formalized guidelines on patient engagement within AI so that we can embed these guidelines into current workflows for AI product development. And I've left my contact information here as well if you'd like to be in touch concerning this study. And that concludes the section of my talk. Thank you.
Thanks so much, Samira. That was fantastic. And we had a really wonderful question in the Q&A that I just want to pose to you. So Janet writes, like with most things, the creators of new technology have their own lived experience as the base to build from. If these creators are usually able-bodied people, how can we be sure that AI solutions will be inclusive of people who look, speak, or move differently than typical folks? So this is getting at the question about who's around the table, and specifically this really important point of most of the time it's able-bodied individuals. So any thoughts on that?
Yeah, for sure. And that's something that I'm trying to actively work to resolve through the research that we're currently conducting to make sure that a wide variety of patient voices are heard. I think it really starts with the participant pools to make sure that we're properly engaging a wide variety of voices to make sure that we're properly informing the conclusions that we're making in the research that we're doing. But it's definitely something that we picked up on in our systematic review, as I mentioned, of the studies that collected demographic information. Many of the individuals had mild or stable in terms of the diseases that they had been diagnosed with. So that's definitely something that we know, and it comes to more actively and proactively working towards incorporation of these voices. So thank you for the question.
Thank you. And our organizers have put the link for those who are interested to your study that you're leading, if people are interested in taking a look and being involved and also sharing it with colleagues. So we'll turn now to Dr. Fan, and she's going to talk to us a bit about the work that she's been doing.
Great, thank you. Good afternoon, everyone, and thanks to Andrew and the Excite organizers for this opportunity to spend a little bit of time with you all today. It feels very meaningful to be at a point in time where AI in healthcare, I think, is still in its infancy, and so we are able to collectively architect its impact on our future. In the work that my colleagues and I do here at the Center for Global Health Innovation to design and develop virtual care models for chronic disease management, it's been really interesting to witness the expectations for our technologies to keep pace with new innovations in AI, but also to understand the reality of what our patients and providers want out of virtual care and what actually works best for them. And so I want to take some time today to show you what AI in health looks like from our side of the fence and how we're thinking of developing our technologies to be more intelligent and to make better decisions. And so most of these smart solutions that I work on can be characterized as rule-based expert systems. And as a very quick primer, rule-based expert systems are designed to solve problems which would usually require a human expert in a particular knowledge domain to resolve. And so they're considered to be the simplest form of artificial intelligence. And despite these really significant advancements in AI methods and applications, rule-based expert systems still remain the dominant application of AI for clinical decision support. And so the if-then rule sets that dictate their decision-making are often based on widely endorsed clinical practice guidelines. And this transparency helps providers to explain and patients to understand system outputs, something that becomes more challenging with systems powered by black box machine learning models, for example. The problem with rule-based expert systems is that they will start to break down when the number of rules is too large and start to conflict with each other. And so for this reason, they're slowly being replaced in healthcare by machine learning algorithms, something that's on our product roadmap as well, and which I'll get into in a little bit. Next slide, please. I want to walk you through a case study today of how we've operationalized one of our rule-based expert systems into a virtual clinic at the Peter Munk Cardiac Center over at the Toronto General Hospital. And so this is the story of our Medley heart failure clinic. Our clinics roughly all share common technological components, namely a patient-facing application. And so in this case, we have the Medley smartphone app, and then a clinician-facing application, which is our Medley dashboard. And patients in the Medley clinic also receive a Medley kit with a Bluetooth weight scale and blood pressure cuff to record their vitals. Next slide, please. And so as a patient, I would use the Medley app every morning to report my weight, blood pressure, heart rate, and heart failure related symptoms. These readings are processed through the rule-based Medley algorithm, and I'm provided with instant feedback on how my readings compare against personalized thresholds, as well as self-care messages for how to manage my symptoms. I'm also able to monitor my health status through reviewing trends in my readings and the history of alerts I've generated over time. Next slide. The concept of alerting in Medley is made possible by the rule-based Medley algorithm, which serves as this expert core to the system that interprets the inputted readings, which you can see at the bottom of the figure, and outputs the appropriate decision at the top of the figure to be acted on by patients and providers. And the rules of this algorithm were developed and vetted by world-renowned cardiologists like Dr. Heather Ross over at UHN, who set the thresholds for readings that would warrant clinical intervention versus those that could be managed through reducing salt and fluid intake or taking an additional Lasix to help with fluid retention, for example. And you can see in the middle of this figure that all of the permutations and interactions between weight, blood pressure, heart rate, and symptoms have been considered and translated into these if-then scenarios, all of which can be clearly mapped out into this matrix of possible outcomes for validation and verification. And so this level of transparency allows us to revisit the algorithm as clinical practice guidelines change and to change the rules, something we've done several times in the decades since the algorithm was first conceived. The downside of this model, which is something that Andrew alluded to at the start, is that it doesn't have the ability to learn new rules on its own or discard ones that aren't working anymore, something that machine learning systems can do rather than being reliant on humans to manually program in these new rules. And so in practice, it means that patients who consistently alert on Medley, but are consistently determined to be fine by their provider, will continue to do so every single time they enter those exact same readings, because the system cannot learn new relationships between input and output and automatically resolve the alert if it detects similar patterns in the data. Next slide, please. And so on the provider side, all of this data, all of these alerts generated from Medley patients will appear on the Medley dashboard for nurse coordinators to review and triage, with those critical red alerts also being sent via email to the cardiologist who serves as the most responsible physician for the patient. And depending on the severity of the alert, nurses will call patients or text them through the in-app Medley Messenger to follow up and make sure they're okay. Patients may also be asked to come into the clinic for further assessment. And this decision to only forward red alerts to the MRP was deliberately made to avoid spamming them with emails and reserving their attention for when it's most needed. Next slide, please. And so in the 3 years that the Medley Clinic has been operational at UHN, we've been able to demonstrate that our rule-based algorithm is pretty good at balancing safety and efficiency for over 1,200 patients living with heart failure. Our number has actually doubled since the pandemic started. And so you can see here that 74% of the daily readings generated by patients do not require clinical intervention and can be resolved through self-care. The remaining 25% are triaged by nurses, with 0.5% of all alerts making their way to the MRP for follow-up. And so due to this advanced clinical decision support functionality, Medley is licensed as a Health Canada Class 2 medical device, which also means that any development work on the system adheres to strict quality management procedures and is compliant with medical device auditing requirements, all to make sure that Medley is safe. And I think this focus on safety is yet another reason why rule-based expert systems remain so pervasive in healthcare. It's no secret that our industry lags behind many others in terms of adopting new innovations. We have so little institutional and professional tolerance for error when it comes to putting our patients at risk of harm that we often favor the most conservative approaches because we equate them with increased safety. What we sometimes forget is that to err is human. And so to build these systems in our own image that cannot learn or adapt without our active intervention may mean that they will remain limited by the flaws and biases of our human nature rather than moving beyond us towards new data-driven ways of minimizing harm. Next slide. And so this potential to improve on the Medley algorithm in new and unexpected ways was the motivation for our partnership with the Vector Institute in 2019 to explore the application of machine learning on the algorithm. One of the issues with the current Medley rule-based algorithm is that it generates a lot of false positives in a deliberate attempt, I should say, to always prioritize patient safety. The justification, of course, being that it's better to be alerted when patients are actually fine than to not be alerted when they are decompensating. And so the goal with this new Medley AI initiative was to explore how machine learning can help to reduce this frequency of false positives and provide more accurate alerts without sacrificing patient safety. This work was led by Dr. Bo Wang, who is the lead scientist of the artificial intelligence team at the Peter Mac Cardiac Center. Dr. Wang took close to 100,000 patient days worth of Medley data generated over the course of 3 years and combined it for the first time with medical record data to create a Medley data set on which a machine learning model could be trained and tested. Next slide, please. This figure is a little bit dense, but I just want to run through a couple of details to explain what Dr. Wang and his team did to improve on the original rule-based Medley algorithm, which is presented in this sort of top teal bar. You can see the data inputted into this algorithm is limited to daily morning readings. And in contrast, the data being inputted into the XGBoost tree-based ensemble machine learning algorithm includes readings from the 2 previous mornings, as well as full medical records. And so to compare the performance of the 2 algorithms, we can look at 4 key values presented in the teal and black text at the top of this figure. You can see that the sensitivity, specificity, and negative predictive power of both algorithms in the black text is comparable and already very high in the rule-based algorithm, with the machine learning algorithm slightly edging it out. However, the positive predictive value in the teal text, which is the probability that someone who alerts on Medley is actually decompensating, is significantly higher with the XGBoost algorithm. And so these findings suggest that Dr. Wang and his team were successful in developing a machine learning version of the Medley algorithm that can reduce the frequency of false positives and provide more accurate alerts, all without sacrificing patient safety. Next slide, please. And so looking more closely at the features that contributed to the positive predictive value of the machine learning algorithm, the team found that from medical record data, higher BNP, lower platelets, having a history of chronic respiratory disease, lower total cholesterol, and lower LDL may increase the risk of decompensation episodes. And from the previous 2-day measurements, the team found that weight change, blood pressure, and heart rate played a vital role in predicting the risk of decompensation episodes. And so overall, it was determined that the inclusion of medical record data, specifically BNP, dramatically improved the predictive ability of the Medley machine learning algorithm and helped to correct the false positive incidents from the original algorithm. What's important here is that from a clinical perspective, all these identified values actually make sense as key contributors to model performance. We're very excited by the progress made to date on the Medley AI algorithm and hope to one day prioritize it as the default algorithm for clinic use. The road from now to then is long and will require close engagement in many of the ways that Samira presented, and partnership with our patients and providers to maintain their trust in the system as it becomes less transparent. And as architects of this system, we will always remain accountable. We should always remain accountable to its users. And so to fulfill this duty, we need to understand how important it is to patients that they know exactly why they did or did not alert on Medley. And we need to be able to provide a logical and satisfactory response and explanation, even if the Medley AI algorithm advances to a point where we aren't quite sure of the answer ourselves. And so with that, I hope that the short case study of Medley as both a rule-based expert system and a machine learning system was helpful in illustrating how AI is applied in virtual care to keep our patients out of hospital, but never too far from the care they need. Thanks so much.
Thank you so much. That was fantastic, and a great example of also a technology that is actually shifting to include, machine learning methods and other forms. I had a question that I was thinking about as you're presenting is also the role of the provider in the loop, or what we call a human in the loop, as part of these types of systems. And has that been something that has come up? And also, are there potential concerns? Because I think for providers, there's often a worry that the integration of these new technologies into our workflows will actually increase our work. So then we're having to pay attention to these alerts or provide feedback. But has that come up, and what have providers been thinking about on that topic?
Yeah, I think it has come up, and actually that was sort of a major motivation for moving to machine learning, because we were seeing our providers feel a bit uncomfortable by the number of alerts that were coming in, and for legal liability reasons, you have to resolve those alerts if you're seeing them, and it also distracts from. If there are so many alerts coming in and there are many false positives and not all of them actually mean decompensation, it will distract providers from actually being able to prioritize and provide timely care to those patients who need it most. And so we've had conversations with our providers where they've expressed that, we need to maintain safety for the patient, and patients want to know that when they are inputting data that somebody is looking at it, but there are levels of doing that while still providing relief and making patients feel at ease, but also, not contributing to clinician burnout. And so in these consultations with our providers, we have many new providers now in the Medley system. At the start, our clinicians were champions of the system, and so are willing to take on a little bit more because they believe in the value of the system. But now that we're onboarding, clinicians who have heard about the Medley program are interested and want to use it organically, I think now we're hearing this feedback that potentially the alerting, needs to be improved. And sort of this was the way that we try to address that.
And I think when Dr. Verma will pick up on this theme too in his presentation. A really brief question. Just final question for you, Dr. Pham, is from the Q&A. Does Medley incorporate data points around medication adherence? And if so, how? Which is a great thought when it comes to congestive heart failure and cardiac care.
Yeah, that's a great question. Thank you. Medication adherence is difficult to track in the medical record, and that is where we're pulling our data. And so, to my knowledge, that is not something that we pull in. However, we track adherence to Medley itself as sort of a proxy for overall adherence to management, with the hypothesis perhaps that if you're not engaged in the Medley program, that you're likely disengaged from your self-care and your medication management. But to point blank answer the question, I don't think that's something we consider because of the data set that we have to work with.
Yeah, it's a great thought, and that we could think about ways to try to incorporate that in either through self-reportory or something like pill count on bottles to check adherence. But it's a great question. I'm going to turn it to Dr. Verma now to talk a bit about his work on CHARTwatch.
Thanks so much, Andrew, and everyone for the fantastic presentations so far. So I'm excited to talk to you a little bit about an artificial intelligence-based early warning system that we have developed here at St. Michael's Hospital with the goal of reducing death for hospitalized patients. So as you know, this audience knows, AI has really worked its way already into clinical care in a variety of ways. We've heard about some of them today. Our focus is on this big green box in the middle here, predictive analytics. Thinking about how to use data into informing predictions that will then drive clinical care. So let's start with a case. So this was a hypothetical case drawn from an amalgam of experiences that I've had directly working as an internist at St. Mike's. So imagine that we have a 73-year-old patient who developed a gallbladder infection, was admitted to hospital and had an advanced GI procedure to remove the gallstone that was causing the infection, and then was planned to be discharged home the next day. But on the day after their procedure, the physician was called at around 6:30 p.m. that the patient was suddenly experiencing shortness of breath. The physician ordered a chest x-ray, some laboratory investigations, and went home for the night, leaving the patient in the care of the nurse and the team in hospital. The patient's vital signs were checked only twice overnight, midnight and around 6 o'clock in the morning. And then when the physician comes back the next day at around 8:30 in the morning, the patient is very unwell, decreased blood pressure, in real distress. The intensive care team was called, but the patient did not want intensive care unit and died that day. And the family was distraught. They would say, we would never have left her bedside. She was suffering. We wish we could have been there. This is a very real example of care that does happen, incidences that do happen in our hospitals, fairly frequently. And it's the notion that the number one cause of unplanned transfer into an intensive care unit or unexplained or unplanned mortality in hospital is a failure to recognize clinical deterioration and to a failure or inability to rescue that patient earlier. So early warning systems have been developed to try to address this very problem. Our general medicine patients in our hospital represent about 40% of the emergency admissions in hospital. And about 8% of general medicine patients die or require an intensive care unit. These early warning systems have been developed and they exist around the world. Most of them are rules-based systems, similar to what Quinn described. So they take a small number of inputs and they say, if your score is a certain number above this, we'll send an alert. And they've been deployed in, for example, more than 3/4 of hospitals in the United Kingdom. And the idea is that they may help clinicians recognize when patients are deteriorating and intervene earlier. One important thing to note about these existing systems is that they have very high false alarm rates. So as many as 9 out of 10 of the alarms sent by that prediction are false alarms. And there's an analogy. Now, the Medley system that Dr. Pham talked about had very good, actually, baseline positive predictive value. Only 1 in 2 of the alarms were false, right? And they got that up to, even a tiny fraction were false alarms. But in this case, again, it's the same problem. It's the problem of too many false alarms. And one of the reasons for this is that these existing rules-based systems recognize clinical deterioration. So they identify, okay, the patient's heart rate is already high. Their respiratory rate is already high. This patient is already deteriorating. So they recognize early signs of deterioration rather than predicting future deterioration. And so we asked, can we deploy machine learning to actually get in the prediction space? So I mentioned that the number one root cause of unplanned transfer to ICU is clinicians failing to rescue patients because they didn't recognize clinical deterioration. And so we asked, can an artificial intelligence-based tool actually help our clinicians intervene earlier? So we developed CHARTwatch to do just that. Use data from the electronic health record to predict unplanned intensive care unit transfers or death in hospital. The goals of deploying this system are to reduce mortality, to improve communication with patients and families so that they can have a better understanding of their risk in hospital, to improve coordination between physicians for the deteriorating patient, and improve early access to end-of-life care for patients in whom it is not part of their wishes to escalate care into an intensive care unit. So we started, it's actually, maybe more than 3 years now. The pandemic makes everyone lose count of things. But we started in late 2017, beginning with engaging physicians, nurses, administrators, and consulting patients and families about, how we could deploy an early warning system like this. We learned from some organizations that are leaders in this space, predominantly based in the United States. And we developed a machine learning model that uses more than 100 data inputs in real time from our electronic medical record to generate hourly predictions that get communicated to our clinicians. We did a real-time clinical validation where we compared model predictions against 3,000 real-time physician and nurse predictions to answer the question, okay, if your model predicts accurately, that's fantastic. But our clinicians asked, how do I know it's better than me? How do I know it's adding value to the care that I provide, that it's providing some information that I don't already have? And so that's why we compared it against real clinical predictions. And then importantly, we designed a clinical care pathway. I mean, the beautiful thing about what we heard about Medley is that it's actually a clinical solution that is IT enabled, not an IT solution that has some clinical application, right? And that we tried to do the same thing here, have a clinical focus, a clinical care pathway that then the machine learning tool sort of enables or triggers or supports. But really the focus is on the clinical intervention. We've developed through the process of building this a 3-phase framework for actually developing and adopting machine learning solutions in clinical practice. Because machine learning is such a resource intensive thing, right? You need data scientists, you need IT professionals, you need a lot of data. We have recommended that all of these projects begin with an exploration phase where you really identify and understand the issue that you're trying to solve and where you focus on, like I mentioned, sort of the clinical workflow, the clinical application. So you establish a team, you specify kind of what you will do with the outputs of a machine learning tool and how this is likely to improve care. You have a real hypothesis, a theory of change, right, for how this will improve care, rather than just beginning with, hey, we're going to predict this really cool thing very accurately, right? That's the machine learning mindset, which is fantastic, but it needs to begin rooted in a clinical problem and a clinical solution. The second part then is deeply designing the solution, which involves the machine learning solution, but also then involves and testing that machine learning solution in real time, but then drawing on all the work you've done in the exploration phase around workflow. And understanding how this solution will affect your clinical workflow. And then finally, an iterative implementation and evaluation where you're constantly tweaking the implementation, drawing on quality improvement methods of the plan, do, study, act cycles. So to develop this team, we had multiple different teams to develop this intervention. We had a model development team, we had a clinical implementation team, we had patient advisors, we had an evaluation committee, and then we had people kind of across all of those teams that were sitting on many teams to kind of pull it all together in a coordinated way. And I think what I just want to highlight here is that this kind of intervention, sort of machine learning, artificial intelligence technologies, and bringing those into a clinical environment is a team sport that requires a lot of different expertise and a lot of different voices. I mentioned already that, so CHARTwatch is more than alert, it's a comprehensive clinical pathway. I'm not going to go into the specific details here, other than to say what we focus on here is really empowering clinicians. So they receive information about a patient in real time. Your patient is high risk, an alert gets pushed to the clinician. And then the clinician makes a decision about, okay, I should go, and we ask the clinicians to go and reassess the patient and use their clinical skills, right? Use all of their own clinical physician and nurse skills and focus their attention on this patient. But we don't prescribe what to do. The technology isn't there yet to be able to say, here's what you should do for the patient. What we can do is say, you should focus on this patient, and then try to identify opportunities to intervene and reduce their risk of deteriorating in the future. So I've kind of covered this, we trained the CHARTwatch model on 20,000 historical patient visits. We compared it to 3,000 clinical predictions. We also compared it to some traditional early warning systems. So just to give you a sense of how well our traditional early warning systems, they are very good at detecting cases, but they have lots of false alarms like I was talking about. Our clinician predictions are a bit better than the traditional early warning system. But detect fewer cases, but at the trade-off of having fewer false alarms. And then our tool is even substantially better than clinicians, right? So it's about 20% better. This is preliminary data for sure. We're still working through the details. It's about 20% better than clinicians at delivering accurate predictions of who to focus their attention. So it's about 20% more accurate. And so this updates physicians in real time when patients are at risk of deterioration. So I'm going to come back to our case because we're close to time here and just say, so the situation can be very different. And now CHARTwatch is deployed since September of 2020 on our units at St. Michael's Hospital on our general internal medicine unit. So when this exact scenario happens, where we have our patient who's undergoing an advanced GI procedure, the alert could come in earlier, right? And so when this physician is called at 6:30, maybe they're doing more. Maybe they're actually intervening with some antibiotics. They're not just handing off the care overnight, right? They're being more attentive. The most important thing is actually that the patient is monitored much more closely because of the high-risk intervention, right? And the ICU team is involved earlier, so they can have conversations with the patient earlier and actually elicit the patient's preferences. Importantly, the palliative care team is also involved, right? And so that this patient who did not want to go to ICU, that decision is made earlier and the palliative care service is involved earlier. And perhaps for me, the single most important thing here is the patient's family is informed and the patient is informed about their risk so that people are not left with the same degree of complicated grief. The idea that we would never have left their bedside. We can convey to them, this person is high risk. Yeah, you can stay overnight tonight, right? And be at their bedside. So I think it's the ability to empower all of these other aspects, better professional clinical care, better coordination among care teams, better information and communication with our patients and their caregivers, which really allows this machine learning artificial intelligence technology to make healthcare more human and better quality care. So that's the work that we're pushing towards. And we're very excited to have shared this with you, and we're still learning a lot along the way. So thanks so much for the opportunity.
Thank you so much for that. And I have a couple of questions specific to the CHARTwatch, but just this is our final slide for those attending. We are going to be emailing everybody who attended a post-section evaluation. Please do fill that out because it helps us improve for the future. We are recording this and it will be available on our website and on YouTube as well. And please do stay in touch with us. And if you want to join our listserv, please email dfcm.excite@utoronto.ca. So now we'll move to kind of general questions, and I think we could end the slideshow. So just starting, Dr. Verma, with your presentation, thank you so much for covering such a lot of ground too in a short period. I had a question because I know you're deploying this in clinical spaces and have been. What's been the feedback from clinicians on receiving CHARTwatch notifications, and what has been their feedback? Because I think, again, providers often they're very worried about how this is going to impact their workflow.
Yeah, I mean, I think we've been fortunate. We spent a lot of time thinking about clinical workflow to the point of, for example, like timing the way we deliver our alerts. So our charge nurses, for example, one of the applications of the CHARTwatch tool is they receive their alerts when they are doing their shift nursing assignments. So assigning a bedside nurse for each patient so that they can make sure one single nurse doesn't have multiple high-risk patients, for example. And so we integrated the communication system so that they get the alerts or they get the updates at the exact time that they're doing their bed assignments, and also in the format, so that we actually replace the previous form that they were using for their nursing assignments, and just integrated it into one system. And so I think we spent a lot of time trying to think about how do we, at the nitty-gritty level, make this integrate with the custom workflow on this unit, right? So I think, fortunately, because of that, actually, we've had very positive feedback that it is not perceived to be disruptive, and it's very useful. For sure, the model is not right all the time, and I routinely get emails saying, "Hey, your model missed this patient," and we've communicated that clearly as part of our training, that we expect this model will probably miss about half of the cases, but will be very accurate in the cases it identifies. And so I occasionally get that kind of feedback, but never the feedback that this is disruptive or burdensome. And we were very careful to try to make that our priority.
That's great. I mean, obviously, a huge part is your close relationship with the care teams, and being both yourself and Fahad and others involved, being part of the team. It kind of speaks to what Samira presented, where when we look at the literature, there's really not a lot of that happening, and not enough, where there's a really close working relationship between the people creating these products, the patients, and the providers as well. So maybe I'll actually pose a question in general to all of you, which almost always comes up with artificial intelligence applications in healthcare, which is the question about privacy and data security. So we're in a time right now when there's enormous amounts of fear about who is seeing our data, where is it getting used to. And as all of you mentioned, all of these programs work by engaging vast amounts of data. So maybe you folks could speak to what's been your thoughts about ways in which we can assure people about the security of data, and also maybe some examples of how that's actually happening. I don't know if anyone wants to take that. Maybe Amol, yeah, do you want to go ahead?
I was actually going to, I'm happy to speak to it. We spend a lot of time thinking about this, but I would assume that Medley has spent a huge amount of time thinking about it, especially because it's an app. So maybe Dr. Pham could tell us a little bit.
Yeah, I was going to say that's the issue of privacy, security, transparency of our data, how we safeguard all of that data is very critical in terms of the way that we approach the development of Medley and all our other digital therapeutics. And that's why in the presentation, I tried to highlight that we follow a QMS procedure, a quality management system for building these types of medical devices. And I think that the regulation of these technologies with a focus on preserving and maintaining data security and making sure that patients understand where their data are going, that they're able to take the data back at any time, that if a Medley patient tells us, I don't want to be in the program anymore, that it's their right for us to remove all of their data from our servers. All of those procedures have been built into the way that to our processes for building this technology. And so I think it has to start from just how our lab is set up, that all of our procedures, everything we have in place prioritizes safety, so that through sort of the continuum of development, those safeguards are built in. We've not experienced to date patients being concerned about how the Medley system has sort of ingested their data to come up with these outputs. A lot of the work that we've done to validate this algorithm has been with our patients and providers. So I feel like there's this sense that, we're co-designing the solution together. But without that sort of community engagement and sort of all of the checks and balances we have in place, I think it would be challenging as a patient for me to believe in a system like Medley.
Thank you. I know we're just coming to time now. Maybe we'll just end with, there's a great question for Samira about, and really for others, if you'd like to weigh in too, about how do we engage and support patient education about AI, I think in general, and then also for specific tools. So we often, I think, are deploying these tools, and they're is a lot of information for patients. How do we support folks to understand this area in general, but then also for maybe specific applications?
Yeah, in terms of supporting individuals and patients learning more about AI, I think it's a lot of the responsibilities placed on those who have the knowledge. So whether they're developers, but more patient-facing, like physicians, to know themselves and where AI is being used and applied and how that can then affect patient care. Having that knowledge base to then be able to sort of engage patients in those conversations and talk about concerns, I think is fundamental for that. I'm not sure if the other co-panelists have any thoughts on how to navigate those conversations, but I think that's a good place to start.
Well, it's just past 1, so we're going to wrap up for today. Thank you all so much for sharing this work. I think the links between engaging patients and providers in design to actual applications like Medley and CHARTwatch was really, really helpful. And really excited to learn about all of these as they move ahead. Thanks to everybody who joined us, and please do keep in touch with Excite for future events and future items that come out of this work. Thanks, everybody.
Thank you.